Menopause is a natural occurrence, generally that occurs in the 5th decade of life. Every woman will go through menopause, and it takes them from their reproductive age to the postmenopausal age group. What I want to do in this lesson is point out some of the pitfalls that are going to come up on the test. A lot of menopause is dealing with menopause, and there's some things out there that you should not do which could trip you up. So over the course of a woman's life, at 11, she has menarche. And at 51, menopause. Some terminology here. It is normal to have some dysfunctional uterine bleeding as periods get going and as they end. But for the most part, in between menarche and menopause is the reproductive age. As she approaches menopause, she becomes perimenopausal, now called the menopause transition. And in this time period, she's going to begin to experience the symptoms of menopause. Irregular cycles, heavier cycles than usual, things are changing, and then eventually they turn off. The pathology of menopause is ovarian failure. And with ovarian failure comes the loss of estrogen and the loss of fertility. The patient is going to experience a number of changes, and these are the things that you have to help her manage. The vasomotor symptoms manifest themselves in the form of hot flashes, also called hot flushes, where she will be warm where everyone else is normal, or she'll actually break out in a hot red flush on her skin. Urogenital atrophy results in vaginal atrophy, which can lead to uncomfortable sex or bleeding after sex, and frequent UTIs. Women after menopause are more likely to get UTIs. And even though women who are postmenopausal may enjoy sex, their libido is often decreased. The things her family or spouse will care about, and they're likely to tell you more than she, is the irritability and mood swings. And all of these things are a product of estrogen withdrawal. And as we said, the definition is the cessation of menstrual periods for 12 consecutive cycles. If the woman is the appropriate age and is developing any of these symptoms, dysfunctional uterine bleeding, or has the loss of periods, diagnosis is done. Menopause is a clinical diagnosis. You should not get any labs or imaging. If they give you labs and imaging, you should know how to interpret it. Because there is decreased estrogen, the anterior pituitary is disinhibited, so you'll see a very elevated FSH. You should not obtain estrogen levels or FSH levels. If you got an ultrasound, you would see no follicles. You should not get an ultrasound in the evaluation of menopause. The time you might do it is if you have premature ovarian failure. Premature ovarian failure or premature menopause occurs in a woman who is less than 40. Menopause is normal over the age of 40, usually around 50, but it can happen in her 40s. So you might work up premature ovarian failure to ensure that's what it is, but still, if menopausal, don't get any lab tests. Don't get any imaging, just call it menopause. And then there are some things we can use to treat some of these symptoms. Some of the things you should do, some of the things you should not. Phytoestrogens for the treatment of hot flashes is a big topic. It is soy products. You can give your patients phytoestrogens, and if it works for her, great. For the test, phytoestrogens do not work. Hormone replacement therapy 40 years ago was thought to be the holy grail of aging. Since after menopause, a woman gets wrinkles, which is accelerated from collagen loss, and starts to feel the symptoms of being old, they thought, well, if estrogen withdrawal happens, maybe we can just give back the estrogen. Systemic estrogen replacement does make the woman feel better, but it also leads to breast cancer. Don't give systemic estrogen therapy. In life, a short course may be okay, but then she'll just go through menopause later as you withdraw the estrogen again. Systemic hormone replacement therapy, not the right answer. For hot flashes, what you should use is the SSRI, specifically venlafaxine. SSRIs have been shown to reduce the vasomotor symptoms associated with menopause and can also help with the irritability and mood swings. Vaginal atrophy can be safely treated with estrogen creams. Topical estrogen improves blood flow and sensitivity of the vaginal tissues and is not systemic, so it does not increase the risk of cancer or DVT. But there's also other stuff you have to keep an eye out for that she may not feel. That is cardiovascular disease and osteoporosis. For cardiovascular disease, you should screen her, get an LDL, and if she meets criteria, get her on a statin. See the medicine videos for cholesterol for more details. But osteoporosis is where I want to spend a little bit of time. Everyone should be screened with the DEXA scan at 65 for all comers, 60 if you're a smoker. And if you identify someone who has osteoporosis based on the DEXA scan, it's bisphosphonates. But as soon as menopause hits, you can help prophylax against this because bone density is going to decrease during menopause. So you want to give her vitamin D and calcium supplements. If you determine that she has a vitamin D deficiency, you're going to replace it with 50,000 units every week. This is a much higher dose than the supplementation vitamin D and calcium. And you're going to recommend exercise. If she uses her bones, especially impact exercise, they will strengthen, and you'll prevent fractures later on in life. Menopause clinical diagnosis. All you're going to do is help her through the symptoms. Don't do phytoestrogens. Don't do systemic hormone replacement therapy. Don't get any labs and imaging. You can use SSRIs for hot flashes, and you can use estrogen cream for vaginal atrophy. You should screen for osteoporosis, supplement as prophylaxis. If you find osteoporosis, treat with bisphosphonates. If you find vitamin D deficiency, treat with vitamin D2, 50,000 units per week. That is menopause.